time for prostate cancer to conclude this reirradiation webinar. Thank you for joining. Throughout this presentation, we will review the optimal diagnosis and re-staging workflow, available local salvage strategies, and the existing evidence on SABR Reirradiation and the role, of course, of the MRI LINAC in this setting. Despite excellent outcomes with primary radical radiotherapy, biochemical recurrence is a reality for many patients. What is interesting, and in this Memorial Sloan Kettering study shows, is that local relapse is the first failure site across all risk groups. However, the proportion of patients receiving local salvage treatment remains disappointingly low, just 2%. Why? By the fear of unacceptable toxicity. So intermittent or lifelong hormone therapy is the standard option in most of the cases, although not exempt, as you already know, of negative impact in quality of life of our patients. But first thing first, how we identify this patient. Traditional Phoenix criteria remains the standard for defining biochemical relapse following primary radiotherapy. But is this criteria obsolete? Moreover, because we are living in the era of such sensitive tool as it is PSMA PET. So guidelines already suggest that it could be justified to request this PSMA PET early than traditional criteria if we have enough clues that our patient is relapsing. How? For the PSA kinetics, we have to take into account short doubling time PSA and short interval. And this makes a lot of sense, given the positivity rates of PSMA PET, as you can see in this table, are quite good, even in low range of PSA. You can see in 0.5, we can have a 50% of possibility of avidity. So nuclear images in lieu of conventional are the gold standard to rule out or confirm local, regional, or distant disease, especially in patients fit and suitable for curative salvage treatment. To complement this full body scan, it is recommended to combine with a multiparametric MRI. For sure, for radiation oncologists, this is really helpful to delimitate the disease, and we will see later how MRI LINAC can help us, but also will help for targeting biopsy. And although biopsy is not mandatory, is highly recommended. You know, we should strongly consider to confirm and characterize the recurrence, given pathological factors can help us to predict the prognosis of our patients and the possibility of distant metastasis recurrent and specific mortality, tumor mortality. Okay, so once we confirm local recurrence, what next? The next step is to decide the best salvage strategy. However, there is a current lack of consensus among guidelines and medical societies regarding the most effective treatment. But what is clear is one-size-fits-all mentality is not proper anymore. It's really important that we have an individualized approach. It is important specialized MDTs, not just in terms of tumor, also in terms of techniques. And in Genesis Care, we apply both. Moreover, in this case that we have to discuss, not just the suitability of in the clinical context, also the technical details, as Dan has mentioned before. So options from invasive, that we have radical prostatectomy, and we know that all the patients are not suitable for that. Minimal invasive, cryo, HIFU, brachytherapy, and that is, we have really long-term and solid results, and really attractive non-invasive techniques, that is external beam radiotherapy. This master meta-analysis review the outcomes of the surgical and no-surgical local salvage option and found no significant difference for 2 and 5 year biochemical free survival between modalities. But guess what? Did find significantly lower rates of severe GU toxicity for any type of radiotherapy. So as I mentioned, brachytherapy is the grandmother in this setting, and we have really solid result and long-term result. But what happened? What was the problem with the previous problem with external beam radiotherapy? So historically, external beam radiotherapy has been associated with unacceptable late toxicity and poor local control. Fortunately, stereotactic ablative radiotherapy came to give a second chance. Thanks to the technologies advanced that we are going to talk about the Moralinac, but another technology as well, we can deliver higher dose in a few number of fractions with really conformal treatment. And these higher dose per fraction are particularly beneficial in prostate cancer, given its low alpha beta ratio. We know that it's around 1.5, so there is a dose response direct relationship with higher dose per fraction with better control outcomes. So the growing interest in SABR is reflected in the increase of the publication over the last decade and 15 years approximately. So although still building this evidence up, we have already series with more than 5 years of follow-up, so it's not bad. Most of them with CyberKnife and with those schedules that try to replicate brachytherapy. So far, the outcomes, as you can see here, really good local controls, 80 to 90%. The 2 years and 5 year biochemical control are in line with the literature of another techniques. The GI toxicity, the gastrointestinal toxicity is practically nil. And then the GU toxicity is quite acceptable. As you can see, the G2 late toxicity is 25% and G3 is less than 10%. But we must acknowledge the heterogeneity in patient selection, prior treatment, salvage radiotherapy regimens, volume volume target in SABR, ADT use, and all of this heterogeneity makes it difficult to draw a firm conclusion in SABR. And despite our European Society published a consensus, we still have an unanswered question, and we try to navigate these uncertainties. I want to highlight the lack of evidence in ADT. I mean, are we applying salvage technique to avoid ADT? What is the optimal target that we have to apply, hemi or whole gland? What is the optimal dose, the optimal constraints, and what is the regimens that we should apply? So briefly, I want to review some points. First of all, whole versus partial gland. In the literature, we have 50-50% reports of whole versus hemi gland. So far, partial treatment volume has been associated, that makes a lot of sense, with lower toxicity. Moreover, lower GI makes a lot of sense because we have a smaller target. But it is interesting that there is no detriment in local control and biochemical control. I have my reservation on that because prostate cancer is a multifocal disease. And although we have a really sensitive tools, I think there is a lot of controversy in this point. Second, optimal dose regimens, a key consideration in the dose-response relationship. And as I mentioned before, we try to replicate brachytherapy with HDR-like regimens. Some series suggest that there is a cutoff on a BED10 of 130 grays, that there is a relationship that higher doses of that leads to better local control. And also I want to highlight the importance of try to dose escalate in the dominant intraprostatic lesions, given this one is known to be the most common site of local relapse. So Dan already mentioned the complexity of reirradiation. So to find an appropriate balance between the delivering and effectively high dose, try to dose escalate, while at the same time achieving to spare OAR, critical OAR. So this is the reason why historically prescription dose for reirradiation were typically modest to prioritize patients safely. But nowadays, dose escalation is under investigation, apart the Dan information gave. Dose escalation, for example, in this phase 1 trial, show the feasibility of doses up to 45 grays, and there is another ongoing trial. So let's see the next or the results. For me, one of the most difficult points of navigating reirradiation, normal tissue tolerance, already Dan and Cassia highlight it, and Dan explained fantastic well how we calculate that. So currently there is no high quality clinical evidence or consensus on optimal constraints, neither for pelvic SABR reirradiation. So as previously has been mentioned, we are following UK SABR Consortium recommendations, and it's really important a case-by-case basis assessment. So throughout this spreadsheet that you can see in the screen, we calculate the margin we have available for each OER, and we are taking into account for sure the prior dose. We are applying a recovery factor depending of the interval in between courses. We are taking into account the alpha beta ratio of each OER, and then finally we achieve a radiobiologically adjust dose constraint for the 5-fraction reirradiation plan. So that's the way that we are trying to standardize this planification. And in our commitment in Genesis Care to the best patient care, also a temporary rectal spacer is implanted in cases of reirradiation. This is a hyaluronic acid device that creates basically a safety margin in between the posterior part of the prostate and the anterior rectal wall, as you can see here. So you, as clinician, you can be more confident to deliver higher doses. And now, my colleagues have already highlighted some of the advantage of MRI LINAC, this cutting-edge technology. Let's review in the case of prostate how we can exploit this advantage. So first of all, here we have the typical image of a CT scan simulation, in which sometimes it's difficult to discern the structuring in pelvic. Here is the same patient, but with the MRI sequences that we use with MRI LINAC for simulation, and you can see the superior soft tissue contrast in the simulation sequences of MRI LINAC that is helping us to control more accurately. This superior soft tissue contrast is also evident in complex cases, such as patients with artificial hips prosthesis. As you can see in the CT scan, is really challenging to delineate. But here is the same patient, and you can see how the MRI LINAC limit, or the MRI sequence of the simulation, limits the artifact, facilitating the control delineation. Moreover, Cassie already shows a really nice case of rectal cancer and how we daily adapt our control to the anatomy, and we also re-optimize our plans. So we are control interfraction variability. And here is quite nice you can compare the baseline scan with the 5 fractions, and you can see how you can appreciate moreover the differences in between the rectum. So that's give us such confidence to treat. And this image superiority also, we have this image superiority also during the whole treatment in real time. Cassie as well show a video, a really nice video in upper GI I think is even more hypnotic, but here you can see how the gas is passing in real time, how it's pushed our target, that is the red line, outside of our confidence margin, that is the yellow one. And a part of this real-time tracking, we have an automated gating. That means that when the red target go out of the yellow margin, the beams literally directly off. I mean, the machine switch off the delivery. So this gives us enough confidence to dose escalate, and moreover in cases of reirradiation. And in case of prostate cancer, also eliminates the need for fiducial markers. Oh, sorry, the video again. So all these features support the rationale of use of MRI LINAC in prostate cancer, representing a paradigm shift, particularly for reirradiation cases where precision is paramount. So we can apply tighter margins. We don't need fiducial. We can't spare with more confident the OERs, critical OERs, and we can minimize these uncertainties and maximize our tumor coverage to try to impact as maximum in the local control of our tumor. Briefly, in the primary prostate scenario, we have the MIRAGE trial phase 2 results. I think it's worthy to mention. MIRAGE trial compare MRI versus CT-guided SABR for localized prostate cancer. The initial findings were published in JAMA Oncology, as you can see here, demonstrating that the MRI-guided SABR significantly reduced acute grade 2 GU toxicity compared to a CT-guided SABR, with nearly 20% less of G2 GU toxicity. And these results were confirmed in a secondary analysis with 2-year outcomes, in which they confirmed the significantly benefit in terms of late GU toxicity. You can see the blue curve that represents the CT-guided arm with a 50% of GU toxicity, and the red line that is the MRI-guided arm with 27%. In addition, MRI-guided SABR was associated with significantly lower of clinical relevant deterioration in bowel function and sexual health. So these outcomes are even more important in the reirradiation setting, but evidence, although encouraging, is still limited. Here I present the Nicosia group results. This study focused on the dosimetric advantage of MRI-guided, highlighting again the improvement in targeting accuracy and sparing of surrounding healthy tissues. So at the end, we are reinforcing the message of MRI-LINAC. But we need further research in terms of safety and efficacy with larger cohorts and longer follow-up, because we have like 2 years of follow-up, retrospectively analysis with a small cohort. Anyway, this study suggests that the SMART in reirradiation setting is safe, with minimal toxicity reported and effective. But as I mentioned, the longest follow-up is 2 years. So I would like to reinforce the message that both of my colleagues have already said, that the importance of the clinical commissioning of this niche of indications, and especially to reinforce the message of collaboration to generate experience-based evidence. And I think this is how this treatment can be mainstreamed. And in Genesis Care, we trying to do that actively, participating in the UK SABR Consortium national audit that it has been already mentioned as well. And also, we want to contribute with our proper experience. So we are analyzing our experience, and hopefully we can publish shortly. We have select in order to create an uniform cohort. We have selected a non-metastatic hormone-sensitive prostate cancer cohort, which in the primary treatment, you can see a wide range of different techniques and different range of regimens. The majority treated with conventional fraction or brachy. I guess that the trend in the future is going to be a different distribution, given we are now treating more with moderate hypo and SABR. I want to highlight that we, in order or towards a standardization, we apply or we restage all the patients with PSMA PET and biopsy. All the patients were treated with 5 fraction, although we apply 2 different dose level, 13.5 and 35 in 5. We try to boost at the same times when the dominant intraprostatic lesion is visible and we can reproduce that. The vast majority of the patients were treated with whole gland, and we allowed ADT, but nearly the half of the cohort spared the ADT. Also, I want to highlight that I think one of the factors that we should consider to patient selection is the prior toxicity. Here I reflect the IPSS, but also we have to consider the GI toxicity to select the proper patients for SABR Reirradiation. So so far, this is our results with a median follow-up of nearly 2 years. 100% of our patients are alive, and 5 patients have a biochemical relapse. Among them, 2 patients have lymph node, local regional lymph node progression disease, and 3 patients had a local persistent recurrence. I want to highlight, because if we come back to the slide of the whole versus hemigland, 2 of these patients with local recurrence had hemigland, and they recur in the contralateral or the not treated hemigland. So here is my point of controversy, that maybe although we have a really sensitive tools, prostate cancer is a multifocal disease, and we have to think carefully what is the proper target. GI toxicity, as you can see, is excellent. Just GI toxicity, no G2 or 5, neither in acute or long term. And yeah, in GU toxicity, we have a slightly higher than literature. We have 4 patients that had G3 late toxicity, but here we can talk about the difficulty of these cases where the target coverage were prioritized over the urethra in these cases. And another case that had a really previous difficult disease with TURP and toxicity. So I reinforce again the message that we should take in consideration all this point. So to conclude and to take home message, again, I think it is really important to have the optimal combination of tests for re-staging. Moreover, if we are in front of fit patients, young patients suitable for salvage local therapies, so combination of PSA kinetics, multiparametric MRI, PSMA PET, and biopsy. Really important, individualized treatment, the importance of specialized MDTs, not just in clinical context wise, also in technique wise. SABR, the evidence that we have so far, offer high local control and favorable toxicity, so it's a really attractive option for our patients with local relapse. I think I can conclude that stereotactic MRI-guided radiotherapy is equal to accuracy and confident. But still, I think a lot of work to do, and we are trying to do our best from Genesis Care to try to help with this lack of consensus, controversies, and to navigate this challenge. I think it's quite encouraging, this evolving landscape, and how our scientific community is increasing its interest. And yes, I just want to reinforce the message that we should create experience-based evidence to create this mainstream scenario.